Okay, welcome everybody to Chapter 16 in Gunstream, and here we're going to be dealing with the urinary system. We'll talk about your kidneys, their location and their function. We'll describe how they get blood and clean it. We'll talk about the structure and function of a nephron, the filtration units of the kidney. We'll talk about how urine is formed. We'll explain how water and electrolyte balance and pH are maintained in body fluid. Explain how nitrogenous wastes are kept within normal limits in body fluid. I will describe the structure and function of the ureters, the urinary bladder and urethra, and the control of micturition, which is urination. We'll talk about the characteristics of urine, what normal urine is composed of, and what abnormal urine is composed of. I will describe some disorders of the urinary system as well. So the urinary system is remarkably simple at first glance. Okay, it's made up of two kidneys, which are about midway down, right in front of the two floating ribs, the last two ribs of the rib cage, 11th and 12th, and they're connected by two tubes called ureters to a bladder, which sits inside the pelvic girdle, and the pelvic girdle encases and protects the bladder. The bladder empties into the urethra, and that's how we expel urine. It maintains the volume and the composition of our body fluids and keeps the electrolyte balance and the pH within normal limits. It also has a major role in the regulation of our blood pressure. Essentially, one of the most important jobs of the kidney is to remove nitrogenous wastes from the blood. Nitrogenous wastes are a byproduct of the breakdown of protein and nucleic acids. An extremely toxic compound called ammonia is the product, and if it were allowed to build up in the tissue fluids in the blood plasma, it would cause the pH to rise above homeostatic limits, and that would create conditions under which membrane potential would be perturbed, and eventually proteins would denature, and the chemical reactions they catalyze would shut down. So, as soon as this nitrogenous waste is produced, it needs to be removed, and the liver and the kidney kind of work hand in hand to do this. The urea cycle is a series of chemical pathways in the liver that allow us to attach ammonia to carbon dioxide to create a molecule of urea. And the urea is easily cleared by the kidneys, becoming part of the urine stream and leaving the body. So very important that we do this on a daily basis. The kidneys participate in regulating blood pressure by either producing more or less urine. The less urine they produce, the greater the fluid volume in the body, thus the greater the blood volume and the greater the blood pressure. And the more urine they produce, the lower the blood volume and the lower the blood pressure. So these guys are major players. They're reddish brown, they're shaped like kidney beans. They are retroperitoneal, meaning they're behind the peritoneum in the abdominal pelvic cavity and very close to the posterior abdominal wall. Again, just underneath the diaphragm, very, very close to the 11th and 12th ribs. As a result, if you get a blow to the lower back in that region, you could easily knock a kidney loose. This is one of the reasons why in contact sports like boxing, ultimate fighting, and football, it's considered illegal, or at the very least dirty pool, to hit somebody in the lower back because you could easily dislodge and damage a kidney. They're located between the levels of T12 and L3 in the vertebral column. They're enclosed in a renal capsule, connective tissue, which supports soft internal tissues, and exterior to the capsule is a layer of fat that also pads and protects the organ. And here's what the kidney looks like. So, relatively simple setup. You can see the renal cortex, which has a lot of blood vessels, and if you dissect a kidney, one of the things that you'll notice is that this region here that I'm tracing with my pointer has a granular appearance, and the reason for that is that there are a lot of coiled tubules and little tiny round structures called Bowman's capsules that populate most of this region of the kidney. Deep to that is the medulla. Now you can see the medulla here. These sort of little striped areas are the pyramids, and they lie in the medulla. The reason these pyramids appear striped is because of the parallel arrangement of the loops of Henle, the vasa recta, which are the blood vessels that run parallel to the loops of Henle, and also the collecting ducts. The renal pyramids are actually where urine is made. The urine is emptied into minor calyces. You can see them here. Okay, and they empty into major calyces. You can see a major calyx here and here and here. Okay, and then the urine collects in the renal sinus, goes to the renal pelvis, and then goes down the ureter, where it'll eventually end up in the bladder. Okay, you can see a zoom up of the junction between the cortex and the medulla here in this inset, and you can see the filtration units of the kidneys that are called nephrons, and you can see the coiled tubes and the Bowman's capsules that populate most of the cortex. So there's thousands of these in each kidney, and they're constantly working to clean your blood. And you can see these big long loops and these collecting ducts that run through the pyramids, and these of course are blood vessels that bring the blood into the kidney to be cleaned and then drain the cleaned blood back into the vena cava via the renal vein. This is what an individual nephron looks like. It is a blood filtering unit. The blood comes in through an afferent arteriole, and a cluster of capillaries called the glomerulus has a very high pressure that forces both good and bad solutes and water through the walls of the filtration membrane, which is made up of the capillary endothelial cells, the basal lamina, and the podocytes, and then into the Bowman's capsule proper. And then this solution flows through the proximal convoluted tubule, down the descending limb of the loop of Henle, up the ascending limb, into the distal convoluted tubule, and then down into the collecting duct, where it'll eventually empty out the tip of the renal papilla, the part of the pyramid here that's right inside the minor calyx, and then from there to the minor calyx, to the major calyces, to the renal sinus and pelvis, and then to the ureter, and then to the bladder, and then out the urethra and out of the body. The hilum is a site where blood vessels, lymphatics, nerves, and ureters either enter or exit the kidney. It's about 12 centimeters long, 7 centimeters wide, and 2.5 centimeters thick. So it's approximately the size of a bar of soap. The renal cortex is the outermost layer that lies just underneath the capsule and right above the medulla, which contains the renal pyramids and the collecting ducts, which extend to the renal papilla and empty into the minor calyx. Renal columns are cortical tissue that are between the renal pyramids, and they're also populated with convoluted tubules and Bowman's capsules. And we should note that the Bowman's capsule plus the blood vessels inside it are called the renal corpuscle. So it's probably more proper to say that they're heavily invested with renal corpuscles. The nephrons are the filtration units of the kidney. They originate in the cortex. The loop then dips down into the medulla and then back to the cortex, and then rejoins the collecting duct, which heads back down through the medulla and then out the tip of the papilla of the renal pyramids and then into the minor calyx. The renal pelvis is medial to the medulla and is continuous with the ureter, and the calyces enclose the renal papillae and direct the urine from the renal papilla into the renal pelvis. The ureter is simply a tube that carries the urine from the kidney down into the bladder. And so here you can see the kidney anatomy, relatively straightforward. The blood that flows into the kidney is coming off the abdominal aorta, and it flows in through the renal artery, and then, as we'll see in a bit, segmental arteries branch into interlobar arteries, which carry blood up the renal columns. They then branch around the ends of the pyramids, forming the arcuate arteries, which give off even tinier branches called interlobular, or sometimes called cortical radiate arteries, and those give off the teeny tiny afferent arterioles that lead into the glomeruli, which then empty into the efferent arterioles, and then there are peritubular capillaries that run all around the loop of Henle, and eventually the cleaned blood is going to rejoin the cortical radiate veins. They'll empty into the arcuate veins, which will empty into the interlobar veins, then into the renal vein, and then back into the inferior vena cava. So that's the blood trip. Okay. There's about 1 million nephrons per kidney. They have two parts, the renal corpuscle and a tubule, and you can see them here. This would be the medullary portion of the kidney, and this will be the cortical portion of the kidney. There's a collecting duct, and if we trace the flow, right, this would be the arcuate artery. This is a cortical radiate artery leading via the afferent arteriole into the glomerulus. The efferent arteriole leads into the peritubular capillaries, which run all around the convoluted tubules and the loop, and then eventually rejoin the cortical radiate veins into the arcuate veins, into the interlobar veins, into the renal vein, and then into the abdominal, or that, sorry, the abdominal vena cava, the inferior vena cava. Okay, the glomerulus is a cluster of capillaries that sits inside the Bowman's capsule, which is a double-walled expansion of the renal tubule, and this is the first place where filtrate collects, which is the first part of producing urine. And you can see here an interesting feature of the glomerulus is that the afferent arteriole is quite a bit wider than the efferent arteriole and is closely abutting both the Bowman's capsule, okay, and also the distal convoluted tubule. Okay, so make special note of that. That's important. The diameter difference is responsible for the high pressures inside the glomerulus that serve to produce hydrostatic pressure that forces solutes and fluid into the Bowman's capsule on its way into the renal tubule. The distal convoluted tubule is bringing filtrate up from the medulla, and it gets very, very close to the afferent and the efferent arterioles. You can see here. And there are cells here called juxtaglomerular cells that sense the osmolarity of the fluid in the distal convoluted tubule and then will adjust the rate at which urine is formed in order to keep a relatively constant electrolyte concentration in the fluid in the distal convoluted tubule. So what it'll do is it'll either open up or choke down on the afferent arteriole. If you open up the afferent arteriole, the glomerular filtration rate and the urine production rate will go up. If you choke down on the afferent arteriole, the reverse will happen. Okay, and so that's how the juxtaglomerular apparatus controls the solute concentration of the fluid in the DCT. They're all talking to each other here. This whole assembly, the macula densa, the juxtaglomerular cells, and the afferent and efferent arteriole, are called the juxtaglomerular apparatus. Okay, so just think of this as one of the ways that we keep the body from losing too much fluid or electrolytes in the urine stream. The renal tubule extends in and out of the medulla. The PCT runs from the glomerular capsule to the nephron loop, whose descending limb dips deep into the medulla and whose ascending limb comes out of the medulla towards the cortex. It's continuous, and eventually it joins up with the distal convoluted tubule, which is going to empty, as we see, into the collecting duct, which will eventually empty into the minor calyx as the urine comes out of the tip of the renal pyramid. Okay, so if you look at the apex of the pyramid, which is the part that's closest to the renal pelvis, closest to the hilum, that's where the urine comes out. The base is actually closest to the cortex. Okay, so it's like an upside down pyramid in a sense. And here you can see how the blood flows through the kidney. You can see how the inner lobar arteries, we can sort of draw them here. Let's see if we can manage to make a little sketch here, show you how this works. If we get the pen here, let's draw in red. I guess that's red. There we go. Okay. So this would be the arcuate artery. This would be the interlobar artery here. So interlobar, abbreviate artery. Okay, right there. Blood flows up through here, through the arcuate artery to the cortical radiates, and then flows via the afferent arteriole into the glomerulus. Efferent arteriole carries the fluid out of the glomerulus and into the peritubular capillaries, and then this flows in very close proximity to the distal and proximal convoluted tubule and the loops of Henle. That close proximity is important for exchanging fluids and electrolytes between these two tubules. And then once that exchange is over, the waste products go into the collecting duct, and the cleaned blood is now in the veins that are wrapped around here, the convoluted tubules. The cortical radiate veins empty into the arcuate vein, which is going to empty into the interlobar vein, to the renal vein, and then back to the inferior vena cava. Okay. Cortical nephrons are about 80% of the total nephrons in each kidney. They have relatively short loops of Henle, and their major job is to detoxify the blood. Their nephron loops are almost entirely in the cortex, while the juxtamedullary nephrons make up the remaining 20%. They have very long loops of Henle that extend deep into the medulla, and they're important in controlling the water content of the blood. So they're carrying the heavy load with regard to fluid balance. Okay. Blood supply, get about 1.2 liters of blood per minute to the kidneys. The renal artery brings the blood in. The interlobars are in the renal columns. They eventually branch into the arcuates, into the cortical radiates, and for the cortical radiates branch into the afferents, which branch into the glomeruli, then to the efferents, then to the peritubular capillaries, and then to peritubular capillaries to the cortical radiate veins, to the interlobar veins, and then to the renal veins. Okay, so you can see all that here. Nice diagram of the blood supply to the kidney. You can live without one kidney. You cannot live without two kidneys unless you go on dialysis. Dialysis comes in two forms. Hemodialysis, where we clean the blood by draining it, putting in a shunt that drains the blood from an artery through a machine that has a semi-permeable membrane that allows free exchange of waste products and saline solution between the blood that runs through this semi-permeable membrane and the dialysis fluid. The formed elements of blood stay entirely inside the tube that's connected to the artery, and eventually that blood is cleaned as a result of osmosis and diffusion with the dialysis fluid and returns back to an artery or to a vein, okay, in the same arm often, and that clean blood now will keep you alive for another few days. If you lose kidney function completely, you got to do this every other day almost in order to stay alive, to avoid the buildup of toxins in the blood that would cause cell and tissue death. The afferent arteriole brings the blood to the glomerulus. The efferents take the blood out of the glomerulus to the peritubular capillaries, which then eventually are going to empty into the cortical radiate veins, to the arcuate veins, to the interlobar veins, and then back to the renal vein, and then to the vena cava. Okay, so that's the blood flow. And again, you can see it here in the diagram. The juxtaglomerular apparatus is found at the point of contact between the DCT and the afferent arteriole. It's a cluster of modified cells that regulates blood pressure by detecting the osmolarity of the fluid in the DCT and adjusting now the diameter of the afferent and the efferent arteriole. So now let's take an overview of what the kidney can do for us. It produces urine, maintaining blood plasma volume and composition within normal limits. It secretes renin, which is responsible for initiating the renin-angiotensin-aldosterone mechanism that allows us, again, to maintain blood pressure. And it secretes erythropoietin, which promotes red blood cell production should they fall below normal. So very important function of the kidney at large. Nephrons perform three basic functions. They regulate the solute concentration and the water concentration in the blood and remove metabolic waste and excess substances from the blood. Or else what would happen is that they would fluctuate to the point where they would cause cell and tissue death. Three processes help these basic functions along. Glomerular filtration, which moves water and solutes from the blood into the nephron to form the filtrate. Tubular reabsorption and secretion, where reabsorption moves useful solutes from the filtrate and returns them to the blood so that we don't lose valuable components such as plasma proteins, water, electrolytes, fuel, okay? All that stuff we need to hold on to. I should mention as a sidebar, it's only if you're below a certain molecular weight that you'll even end up in the filtrate and be reclaimed by reabsorption. This is why the formed elements of blood and the plasma proteins are seldom found in the urine stream because they never actually penetrate the filtration membrane of the glomerulus and make it into the Bowman's capsule. So if we see any of those components in the filtrate or in the urine stream, we know that there is something wrong with the kidney function. Secretion moves waste and excess substances from the blood into the filtrate, so again, we can maintain homeostatic limits on those components. Water reabsorption is critical. The kidneys remove water from the filtrate and return it to the blood. You can see these three processes in this diagram of the nephron here. Notice here that we've got a renal corpuscle, and then this is meant to represent the renal tubule and the collecting duct, okay, as well as the bladder and the urethra. And then this is meant to represent the glomerulus, the peritubular capillaries, and eventually the cleaned blood rejoining now the venous return via the hookup between the peritubular capillaries and the cortical radiant veins, which eventually, as we already know, will lead to the renal vein and into the inferior vena cava. Okay? So, very important. Reabsorption, again, reclaiming useful stuff and putting it back in the blood. Secretion, putting garbage into the urine stream. Filtration, forcing stuff below a certain molecular weight into the Bowman's capsule. And then water reabsorption really happens at most points along the renal tubule and is controlled hormonally so that we can maintain blood volume and blood pressure. Glomerular filtration forces water and solutes from the blood into the glomerular capsule. Two factors promote filtration: the permeability of the glomerular capillary walls, the endothelial cells, that allows water and dissolved substances to pass through, provided they're below a certain molecular weight. Those components that are too big stay in the blood, and those include the formed elements and the larger plasma proteins. You can see the components of the filtration membrane here. The endothelial cells, the basal lamina, and the podocytes together allow only molecules below a certain molecular weight into the Bowmans to become part of the filtrate. And then the next task, of course, is to recover the useful solutes, put it back into the blood, and then leave the waste products in the urine stream. The high blood pressure within the glomerulus promotes filtration because of the difference in diameter between afferent and efferent arterioles. Pressure builds up. That hydrostatic pressure, along with osmotic pressure, produces a net filtration pressure that causes us to continue to make urine all the time. It's usually much lower in the systemic capillaries than it is in the glomerulus. If we had blood pressures in the glomerulus that were equal to what we see in the body capillaries at large, we wouldn't have enough physical force to produce filtrate and thus make urine. And this is one of the reasons why the body takes great pains to try and maintain that hydrostatic pressure within the glomerulus, and that's how the juxtaglomerular apparatus, as well as the renin-angiotensin-aldosterone system, work together in order to maintain those values. If we were to bleed out, okay, or lose systemic blood pressure for some reason rapidly, eventually the kidneys would shut down because there wouldn't be enough hydrostatic pressure in the glomeruli to promote the production of urine. Now, the filtrate is the fluid that enters the glomerular capsule from the glomerular fluid. Okay, remember, it has to cross the filtration membrane, which are the endothelial cells, the basal lamina, and the podocytes, in order to gain access to the Bowman's capsule. It's got the same composition with blood plasma, but without the plasma proteins and the formed elements, which are too large to cross through the filtration membrane. The filtration rate on average is about 125 milliliters per minute, so your entire blood volume is filtered every 40 minutes, and most of this filtrate ends up back in the bloodstream. Remember that a stable glomerular filtration rate is necessary for normal body fluid balance. A change in the glomerular blood pressure will change the GFR. A rise in the glomerular blood pressure will increase GFR and urine output, and a reduction in glomerular blood pressure will reduce GFR and drop urine output. So very important that we understand that, as we mentioned earlier, the production of urine is dependent in large part due to the hydrostatic pressure in the glomerulus, and if we were to lose systemic blood pressure dramatically, we would cease making urine and would go into kidney failure. There's three mechanisms that help maintain a stable glomerular filtration rate: autoregulation, which is in basically charge of adjusting to normal fluctuations in systemic blood pressure, primarily by changing the diameter of the afferent and efferent arterioles. Sympathetic nervous system stimulation for big drops in systemic blood pressure. Remember that the sympathetic division of the ANS tends to raise systemic BP, while the parasympathetic tends to drop it. And then the renin-angiotensin-aldosterone mechanism for severe drops in systemic blood pressure that are going to be governed by a hormonal axis. So let's look at each of these in detail. Renal autoregulation is just adjusting the diameter of the afferent and efferent arterioles to keep blood flow within normal limits and keep GFR constant. Sympathetic influence causes the systemic blood pressure to go up as a result of systemic vasoconstriction, routing blood primarily to the muscles and the connective tissue in order to deal with an emergency situation, and at the same time reducing blood flow to organs like the kidney so that blood volume and blood pressure stay high. The renin-angiotensin-aldosterone mechanism is a chemical control network that raises blood pressure by inducing thirst, constricting arterioles, and conserving water by reducing urine output by two mechanisms. One, by recovering more water in the DCT and in the collecting ducts by making them more permeable to water, and as a result easier to recover and load back into the blood. And also by aldosterone, which is a salt retaining hormone the more salt that we retain at the DCT, the more fluid will passively follow, and the result is an increase in blood pressure and blood volume as well. So this is the renin-angiotensin mechanism in diagram. A low glomerular filtration rate triggers the conversion of angiotensinogen to angiotensin 1 via the protein renin produced by the kidneys. In the lungs, ACE, angiotensin converting enzyme, changes angiotensin 1 to angiotensin 2, and angiotensin 2 has a variety of effects. It causes systemic vasoconstriction, which raises systemic blood pressure. It causes increased aldosterone secretion, which causes, as a result, increased fluid recovery, increased blood volume and blood pressure. It results in increased AD8 secretion, which causes greater water permeability at the DCT and the collecting duct. The result is that we recover more fluid and load that back into the kidney and then back into the blood, increasing blood volume and blood pressure, and increased thirst, where we seek out fluids, and the result is an increase in blood volume and blood pressure. So all these are designed, again, to get that BP back up. You've probably heard of a class of drugs called ACE inhibitors that are used to control hypertension, which is blood pressure that's abnormally high all the time. It works by reducing the rate at which angiotensin 1 is converted into angiotensin 2. The result is that there's less systemic vasoconstriction, there's less induction of thirst, there's less aldosterone and AD8 secretion, and the result is that the blood volume and the blood pressure stay low. So let's look at tubular reabsorption and secretion. It involves two types of transport mechanisms. Active transport that uses ATP and membrane proteins. The molecules are, as a result, moved against their gradient using the power of ATP to drive that movement. And passive transport, such as diffusion, osmosis, and facilitated diffusion, that works by utilizing the concentration gradients in order to drive a particular solute or a fluid from one compartment into another. We also have to take into account electrochemical gradients as well. When we're talking about ions, we have to consider the fact that in the kidney, the critical ions have positive charges, and so they're going to be attracted to negatively charged fluids or fluid compartments and repelled by positively charged ones. So that's another important consideration. Its effectiveness depends on the permeability of the tubule to the substance and the concentration gradient of the substance. The greater the permeability, the greater the movement permitted. The steeper the concentration gradient, the more movement of that solute down its gradient and either into the blood or out of the blood, depending on which process we're talking about, reabsorption or secretion. So to learn how this process works, we have to consider all the events in the renal tubule as separate processes occurring in different locations. So you can think of the renal tubule really as a series of tubes stitched together where different processes happen in different portions of the tubule. In the PCT, 65% of the filtrate is reabsorbed. This includes the sugars, the amino acids, and a large amount of water and electrolytes. Most of this is active transport. There is also osmosis and some passive transport. An increase in osmotic pressure in the blood plasma causes the water to be reabsorbed. The water, remember, is going to follow the solutes wherever it goes. That's essentially the way osmosis works, is that water will chase solutes, whether they're moving passively or actively, from one fluid compartment to another across a semi-permeable membrane. Tubular secretion is a different process, and it moves drugs, histamine, ammonia, uric acid, and protons from the blood into the filtrate, where they're going to be eventually excreted in the urine. So this is a similar process working in the opposite direction. So here you can see an example of the setup. Nutrients, nutrient-rich blood, flows into the glomerulus and as a result enters the Bowman's capsule, where hydrostatic and osmotic pressure force filtrate production into the Bowman's, and then that filtrate enters the proximal convoluted tubule. What happens here is that we recover the bulk of the nutrients and water and electrolytes, and we put it back into the bloodstream. So that's reabsorption. What's left over are waste products, a relatively small amount of water considering the amount of filtrate that's produced, and some electrolytes. So we can see here PCT activity. Negatively charged ions like bicarbonate and chloride are passively reabsorbed, while amino acids, glucose, sodium, potassium, calcium are all actively pumped back into the bloodstream. And water follows by osmosis. So here you can see a zoom up of this little area between the blood vessel and the tubule. They're in very close proximity, so these solutes and liquids don't have to go far to move from one fluid compartment, here the lumen of the tubule, to the bloodstream, and that's by design. In the nephron loop, in the thin descending limb, we are impermeable to solutes but very permeable to water. So water tends to leave the filtrate and enter the kidney, and this is primarily through osmosis. Okay, so this is not an active process. By the time the solute laden filtrate gets to the bend in the loop, the osmolarity is quite high. But right at the bend in the loop changes its properties, and in the thin ascending limb, we become impermeable to water, but we actively pump the sodium out of the filtrate and into the kidney. Okay, so the result is that the osmolarity drops as we head back up towards the cortex. Okay, so very important that we understand that. In the thick ascending limb, this process continues in earnest. Okay, so really what's happening here as we drop down into the medulla is we're losing water and gaining osmolarity for the filtrate, and as we head back up in the opposite direction, we are actively pumping solutes into the kidney and reducing osmolarity in the filtrate. So by the time we get back to the distal convoluted tubule, the osmolarity is close to what it was when it left the proximal convoluted tubule. And you might initially think that that was a pointless exercise, but the utility of doing this is that it creates a salt gradient in the medulla of the kidney that will ultimately be used to adjust the water content of the urine as it passes through the DCT and then the collecting duct, which dips down through the medulla one last time. So that's the purpose of that whole process. Sodium and chloride are reabsorbed by the thick ascending limb, remains in the kidney's interstitial fluid, and creates a solute water environment that allows for water reabsorption in the collecting duct proportional to its permeability to water, which is determined by a membrane protein called aquaporin. Tubular secretion does not occur in this region. When we leave the nephron loop, the filtrate has 20% of the water and 10% of the filtered solutes that it had entering the loop. The events in the distal convoluted tubule include the action of aldosterone, which causes reabsorption of sodium and thus retention of water via osmosis. The electrochemical attraction reabsorbs chloride and bicarbonate. Water reabsorption occurs because of, again, the passive movement of water down its concentration gradient. So the water chases the solutes back into the bloodstream. This is under the control of a hormone called antidiuretic hormone, which induces the production of aquaporins in the DCT and in the collecting duct. And essentially, the more permeable the DCT and collecting duct are to water, the more water will be recovered, the more concentrated the urine will become, and the greater the blood pressure and the blood volume. Potassium is secreted in response to aldosterone while sodium is retained. Protons are also secreted to maintain normal blood pH. So the kidneys can do an interesting trick, which is they can either produce an acidic or a basic urine in response to fluctuations in pH in the bloodstream. And that's important because we don't want the body's pH to get too high or too low. The result would be a loss of homeostasis and death of cells and tissues. In the collecting duct, as it descends through the renal pyramid, the interstitial fluid concentration of ions goes up as we drop down through the salt gradient in the medulla, and water is stolen from the collecting duct by osmosis, re-enters the kidney, and then goes back into the bloodstream. The result is that we generate a concentrated urine most of the time. ADH makes the collecting duct more permeable to water, which makes the urine concentrated and reduces the urine output. If we don't make adequate ADH, we're going to make large volumes of dilute urine, and we might end up with dehydration, and that's actually a hallmark of a disease called diabetes insipidus, where ADH production is inadequate and the patient suffers from polyuria, which is excessive urination, and polydipsia, which is excessive thirst. Final urine normally contains only 1% of the original filtrate volume. Now, how do we maintain blood plasma? Food and liquid intake provide water and nutrients that are absorbed into the blood. Metabolism uses the nutrients and releases waste products that we have to clear. Urine production retains essential nutrients and minerals and excretes excess substances and wastes. Healthy kidneys keep the blood volume and composition constant, so that's why they're so critical to normal metabolism and homeostasis. And this is despite the constant changes that are produced by a fluctuating diet and by the activities of metabolism. Okay, let's talk a little bit about electrolyte and water balance, which are really two parts of the same coin. Water is the solvent of the body where chemical reactions occur. It also has a high heat capacity and as a result helps to maintain body temperature. So a lot of good things about water. It's a liquid, so it allows molecular motion. It dissolves a lot of solutes, and as a result they can interact chemically. So all very important properties of water. Electrolytes are charged substances that are dissolved in water. They conduct electricity, and they also govern the movement of water. The concentration of one is going to affect the concentration of the other. Basically, the easiest way to remember this is that water will go where the solutes go. So water, just like a solute, will move down its concentration gradient from where it's most to where it's least concentrated. Water intake is regulated by our thirst center in the hypothalamus, which is activated by a reduction in water concentration in the blood and the production of angiotensin II when blood pressure drops. The result is we seek out fluids that causes the blood volume and the blood pressure to rise. Water is lost by a variety of pathways, about 6% in the sweat, about 6% in the feces, and about 28% through insensible perspiration and respiration. In this case, we're referring to really ventilation of the lungs. And then we lose about 60% in the urine. So water input and water output balance each other. If we have an imbalance, then we're going to have a shift in electrolyte concentration, and that's going to adversely affect cell function. The volume of water lost in the urine depends on what is lost through other means. Excessive loss by other means is going to reduce urine output, causing a concentrated urine to be produced by the kidneys, and minimal loss by other means results in an increase in urine output. So we generate a more dilute urine. A way to know whether your urine is concentrated or dilute is to look at the color. Essentially, urine that's a dark yellow or orange is highly concentrated. Urine that is pale yellow or clear is relatively dilute. Urochrome is the yellow pigment in urine that's derived from hemoglobin that gives it its color. Water intake impacts water reabsorption in the kidneys. The greater the water intake, the more urine production you're going to have. Again, to maintain fluid balance. A low water intake will reduce the urine output and increase the urine concentration. ADH controls whether more or less water is absorbed than normal. Basically, when large amounts of ADH are produced, we retain more water that causes the blood pressure and blood volume to go up and the urine production to go down. And this acts again on the collecting ducts and the DCT. So a high blood water concentration means less ADH production. As a result, less water is absorbed and the urine volume goes up, and the blood pressure and the blood volume go down. So very important that we understand how those are related to each other. If they're not functioning properly, then we're going to create either a hyperosmotic or hypoosmotic condition around cells and tissues, and that's going to impede their function, could in fact kill them. Okay, the important electrolytes are sodium, potassium, calcium, chloride, phosphate, sulfate, and bicarbonate. They're obtained through our food. Salt cravings are usually due to low electrolyte concentrations. The balance is maintained by active transport of sodium. Passive reabsorption of negative ions occurs by electrochemical attraction. Basically, opposite charges are attracted to each other. So where the sodium goes, the chloride, the bicarbonate, the sulfate, the phosphate will follow. Okay. Now, aldosterone stimulates reabsorption of sodium and secretion of potassium in the distal convoluted tubule. At the same time, this also increases water retention, resulting in an increase in blood pressure and blood volume. The hormone is produced in the adrenal cortex in response to an increase in blood potassium or a decrease in blood sodium. Angiotensin II also stimulates its secretion. Remember that the ultimate outcome of angiotensin II secretion is an increase in blood pressure and blood volume. If sodium and potassium are normal, aldosterone is not produced. You might ask me, well, what organ makes aldosterone? And the answer is the outer layer of the adrenal cortex, the zona glomerulosa. Okay, and those are right atop each kidney. Parathyroid hormone is responsible for increasing blood calcium levels. It does so by increasing calcium reabsorption in the renal tubules, increasing reabsorption of calcium from bone into blood, and also from the small intestine. The result is that blood calcium levels go up. PTH production ends when blood levels of calcium return to normal. Calcitonin has the opposite effect. It decreases blood calcium levels by mineralizing bone, and the result now is that we keep our blood calcium within nice tight limits. Now, a word about calcium. Okay, I'm sure that the first thing that leaps to mind when you think about calcium is that it builds strong bones, and that's absolutely true. It's a component of hydroxyapatite, which is the hard stuff in bones. But calcium is also critically important for many other biological processes, among them nerve transmission, muscle contraction, and blood clotting. Okay, all rely on calcium. It's also a potent cellular signaling molecule. Okay, and it has a effect as well on membrane potential, as we're going to find out. Nitrogenous wastes are built up as a result of the metabolism of nucleic acids and proteins which contain nitrogen. The kidneys remove enough to keep the blood levels within tolerable limits by excreting urea, which is actually manufactured in the liver via the urea cycle, where two ammonia molecules combine with a carbon dioxide make a molecule of urea. Ammonia would be very toxic if it weren't coupled to carbon dioxide, and this is why the kidney has to engage in the production of this waste product, which is then excreted by the kidneys into the urine stream. 40% of filtered urea is reabsorbed and is used by the kidney to help establish the concentration gradient in the medulla, and the rest is excreted as a waste product. Uric acid is a waste product of nucleic acid breakdown. Most of it is reabsorbed. Enough is secreted to keep blood levels within a normal range. If uric acid builds up too much, that can produce stones. Okay, very uncomfortable. These stones can accumulate in the kidneys. They can accumulate in the blood. They can accumulate in the tubules. Okay, so we have to keep a sharp eye for uric acid so that it doesn't crystallize out. Gout is an example of what happens when we don't clear this adequately as a result of kidney excretion. These crystals form in the joints and produces a very painful sensation inside the joint capsule, particularly in distal areas of the body that are lower temperature than the body core. Creatinine is a waste product of muscle metabolism. It's actively secreted by the distal convoluted tubule. The kidney also has a major role in pH balance. Normal blood pH is between 7.35 and 4.5. Metabolism produces products that tend to make the blood more acidic. So what you're looking at here is just a flow chart showing you how different processes change the chemical composition of the body's fluid compartments. You can see here how respiration, both anaerobic and aerobic, produce byproducts that can alter the pH. The breakdown of proteins and nucleic acids can generate phosphoric acid, which can change the pH. Ketones, which are organic acids that are the result of fat breakdown, can alter the pH, and the oxidation of amino acids that contain sulfur, like methionine and cysteine, can generate sulfuric acid and change the pH. All of these tend to lower the pH, and so what the kidneys will do in response is excrete protons into the urine, generating an acidic urine and bringing the blood pH back up to normal levels. Okay, now the next thing we need to address is the definition of an acid and a base in order to broaden our understanding of pH. And basically an acid is any compound that releases protons in water. Protons are simply hydrogen ions. The more protons are released, the stronger the acid becomes and the greater effect it has on reducing the pH value. A base, on the other hand, releases ions that combine with protons and decrease their concentration in solution. Our body fluids have both acids and bases that come from a variety of sources. Some are inorganic and some are organic. A buffer is essentially a system of solutes that prevents a rapid shift in pH upon challenge with either an acid or a base. They can combine with or release protons in order to stabilize pH, and as a result, they're critically important in maintaining the pH in most fluid cavities in the body at or around 7. Range usually accepted is 7.35 to 7.45. So the kidneys play a role in this as well. They have the ability to excrete either an acidic or a basic urine in response to a change in physiological pH in order to keep our body pH within that tight range. Protons are secreted into the distal convoluted tubule to help buffers to maintain homeostatic pH. Exhaling carbon dioxide also helps excrete excess protons. Carbon dioxide is carried in the blood as bicarbonate and free protons. An increase in carbon dioxide production causes a decrease in pH because the carbon dioxide combines with water to form carbonic acid, which in turn will dissociate to produce protons and bicarbonate. Increasing the rate of breathing removes excess carbon dioxide, results in the formation of carbonic acid from free protons and bicarbonate, and ultimately the removal of carbon dioxide when we exhale has to be filled by the equilibrium shifting back towards the creation of more carbon dioxide, which means we tend to consume protons. Low proton levels will cause a decrease in our breathing rate, while high proton levels will cause an increase in our breathing rate. So these three systems together, buffers, the respiratory and the urinary system, all combine to try and stabilize the pH of the body. To review, a buffer system is simply a combination of solutes in a solution that has the ability to either combine with or release protons when it's challenged with an acid or a base. And the result is that the pH changes relatively little in the face of such a challenge. The urinary system stabilizes pH by either producing an acidic or a basic urine in response to a change in physiological pH, and the respiratory system either increases or decreases the rate and depth of respiration in order to blow off or retain more carbon dioxide as the body pH changes as well. It's thought basically that the respiratory system is rapid acting but has a low capacity for shifting body pH. The urinary system is slow acting but has a tremendous capacity to change the body's pH. And the buffer systems work in concert with both of these other systems in order to keep the pH in most body compartments between 7.35 and 7.45. Now you might well wonder, why is that so important? And the answer to the question is that if the pH were to rise or to fall too much, we would change membrane potential. The result is that cells wouldn't be able to use that separation of charge as a source of energy to perform cellular work, and the cells might likely die. In addition, a rapid shift in pH could affect the secondary and tertiary and quaternary structure of proteins that catalyze chemical reactions in living cells. The result would be that those chemical reactions would stop and the cell would likely die. So that's why it's important to keep the pH within these nice tight limits. Now, let's examine the rest of the anatomy of the urinary system. The ureters are the tubes that connect the kidneys to the bladder, and the wall has three layers: an outer fibrous layer, a middle layer of smooth muscle that uses peristalsis to help propel the urine down to the bladder, and the inner layer, which is a mucous membrane that provides lubrication and forms a flap to prevent urine moving from the bladder into the ureter. And we don't want that to happen, because if that were to occur, the pressure that would build up could likely damage the nephrons in the kidney, and over time that could result in a decrease in kidney function. And this is in fact what happens in a condition known as renal calculi. Kidney stones, as they're more commonly known, often lodge in the ureter, producing a back pressure that crushes nephrons in the kidney. Over time, that can reduce kidney function, could even potentially lead to kidney failure. Okay? The urinary bladder is a hollow muscular organ in the pelvic cavity surrounded by the coxal bones, and it's there for temporary storage of urine. It changes its shape depending on how much urine it contains. It has inner foldings called rugae that vanish as the organ begins to fill up with urine. You can see here the distended state of the organ. The trigony is a triangular area bounded by the two openings that provide entrance for the ureters into the bladder. You can see them here, and also the urethral opening. Okay? The reason we make a big deal out of the trigony is because this is frequently where bacterial infection sets up, usually in individuals that have reduced output, and this is often seen in the elderly. There's also a greater risk of urinary bladder infection in women compared to men, primarily because of the difference in the length of the urethra. Okay? The bladder wall has four layers. The innermost is a mucosa that's lined with transitional epithelium, which can stretch and snap back depending on how much fluid is held in the bladder. The submucosa supports the mucosa and contains elastin, blood vessels, and nerves. The third layer is smooth muscle, known as the detrusor, that contracts to expel urine, and it forms the internal urethral sphincter, which must be relaxed along with the external urethral sphincter in order for urination to commence. The urethra is much wider in diameter than the ureters and carries urine from the bladder to the outside. The wall has smooth muscle and connective tissue. The innermost layer, again, mucous membrane. The middle layer, again, smooth muscle. And the superficial layer, connective tissue. The external urethral sphincter is made up of skeletal muscle fiber. In females, it's about 3.5 centimeters long and opens in front of the vagina. In males, it's about 18 centimeters long and opens at the tip of the penis. This has a consequence. It means that bacterial infection is much less likely to set up in men than in women for two reasons. The longer urethra means that the bacteria have further to travel to get into the bladder. In addition, the urethral opening is further from the anus. As a result, the risk of infection is reduced. Micturition is simply the act of urination. The bladder can hold about a liter of urine, but the urge to urinate begins when it's a little under half full. The micturition reflex is triggered when the bladder stretches. Parasympathetic impulses cause the detrusor muscle to contract. The internal urethral sphincter opens. If the external urethral sphincter relaxes, urination can commence. But if the external urethral sphincter is closed, urination will not commence. But we can't postpone this indefinitely. Once the bladder gets over half full, then the release of urine will commence regardless of voluntary efforts to keep the external sphincter closed. Often, the sphincters can weaken as we age, and this can result in incontinence. There are therapies as well as medications, as well as exercises to deal with incontinence, but it is a problem due to the loss of muscle tone and a problem with innervation of the detrusor and the muscles of the sphincter that are less effective as we age. Now, urine is a sterile solution while it's still inside the body, although it is quite toxic. You make about 2 liters of urine every 24 hours. It should be pale yellow to light amber due to the presence of urochrome, which is a breakdown product of hemoglobin. It may or may not have an odor depending on our diet and depending on other factors, such as whether or not there is a bladder infection, a UTI. It's usually slightly acidic, although this varies widely with diet. The specific gravity is greater than water due to the presence of dissolved solutes in the urine. And there are certain compounds that we do not expect to find in urine if physiology is operating normally, and that includes glucose, proteins, red and white blood cells, hemoglobin, and bile pigments. If these are present in the urine, which can be detected by a dipstick test, then there's a problem somewhere along the urinary tract. Could be at the level of the kidneys, could be within the ureter, okay, could be within the urinary bladder. So let's look at some urinary system disorders. We group them into inflammatory and non-inflammatory disorders. Cystitis is an inflammation of the bladder from bacterial infection. As we noted earlier, females are more susceptible due to the short urethra and its proximity to the anus. Glomerulonephritis is inflammation that involves the glomeruli, again due to bacteria or bacterial toxins. It causes an increase in glomerular permeability. As a result, we frequently find protein and blood in the urine where we don't expect it. Okay, and again, we can pick this up with a dipstick test. Pyelonephritis is inflammation of the renal pelvis and nephrons. Remember that the renal pelvis is that portion of that section of tubing above the ureter that is between the renal sinus and the ureter where urine collects. We can also see inflammation of the nephrons, the filtering units of the kidney. Pyelitis is just the renal pelvis inflamed. And again, this is caused by bacteria generally moving into the urinary tract, often from the urethral opening. Okay, and again, this is more frequent in women than in men for the reasons we've previously discussed. Urethritis is an inflammation of the urethra, can be caused by E. coli as well as other bacteria. It's quite common in females, and it's also common in individuals who have reduced urine output. The urine, remember, acts as a sterilant for the urinary tract. As a result, the more you urinate, the more sterile, so to speak, the entire urinary system remains. Okay, so it's a good idea, again, to produce at least 1.5 liters of urine a day for that reason alone. Non-inflammatory disorders include diuresis, which is excessive production of urine. This can be due to inadequate reabsorption of water, and it is a symptom of a condition known as diabetes insipidus, where we don't make sufficient amounts of ADH, antidiuretic hormone. Basically, the result of that is that the collecting duct and the DCT remain relatively water impermeable. As a result, you produce copious amounts of dilute urine, and the hallmarks of this are polyuria and polydipsia. Polyuria, excessive urination; polydipsia, excessive thirst. Renal calculi are kidney stones that can be the result of the crystallization of either uric acid, calcium, or magnesium. They're extremely painful. They often present as referred pain radiating through the abdomen and the inguinal region. They can be caused by the use of diuretics. They can be caused by hormone imbalance. Essentially, the stone has to be caught and chemically analyzed in order for a proper diagnosis and a proper recommendation to be made with regard to a change in diet and lifestyle. Ultrasound can break up the stones, shatter them so that they can easily pass. A very frequent diagnostic for this condition is hematuria, blood in the urine, because these stones are frequently quite sharp and they cut the ureter as they move through it, and the blood ends up in the urine stream. Renal failure is the reduction in urine output and failure to maintain body fluid volume and composition. It can occur acutely or chronically and causes uremia and anuria. Uremia and anuria are two conditions. Anuria is simply a lack of urination, and uremia is literally urine in the blood. And this is an extremely dangerous condition because the urea is a powerful base. It causes the pH of body fluids to rise dramatically. That can result in the denaturation of proteins and the perturbation of membrane potential. Hemodialysis or kidney transplant is often the only solution to renal failure. And the problem, of course, with a kidney transplant is that the donor tissue has to be histocompatible. As a result, most successful transplants are from living related donors. You can live without one kidney functioning, but you cannot live without two. Hemodialysis is more of a stopgap measure. In order to substitute for kidney function, we can hook you up to a machine which runs the waste-ridden blood through a semi-permeable membrane bathed in a dialysis solution, and basically osmosis and diffusion remove the waste products. A dialysis solution is generally physiological saline. We may include physiological glucose in there as well. The bottom line is that this is a temporary method of cleaning the blood. It has to be done about every other day. There's an alternative called peritoneal dialysis that can be performed in the home, where a port is put into the abdomen, which is then filled with the dialysis fluid by a trained nurse or nurse practitioner or home care assistant. The dialysis fluid in the peritoneum allows the waste products from the heavily vascularized peritoneal membrane to move into the dialysis fluid, which is then drained off, and that results in cleaning of the blood without having to be hooked up to fancy machinery. The advantage of this is it can be done in the home, and the patient doesn't have to travel to a dialysis clinic every other day. And it was actually the first form of dialysis discovered during the Civil War, when soldiers would come off the battlefield with shrapnel wounds, and they found that by bathing the peritoneal cavity with diazolate, they could clean the blood. Okay, stay tuned for some excellent videos on urinary system function, and I'll join everybody in the next podcast. Thank you.
One kidney lies on each side of your vertebral column. The kidneys are the primary organs concerned with body fluid and electrolyte regulation. Unneeded fluid and ions are excreted in the urine. Also contained in the urine are metabolic waste products such as urea and uric acid, which form during the breakdown of proteins and nucleic acid. The combination of water, ions, and waste leave the kidneys as urine, which flows through the ureters and into the urinary bladder, which will store the urine until it passes out of the body through the urethra. A renal artery supplies each kidney with blood. The blood is distributed to over 1 million nephrons, the functional units of the kidney. Nephrons are found in the cortex and medulla of the kidney. Each nephron is composed of the renal corpuscle and a renal tubule. The renal corpuscle has two parts, a spherical capillary cluster called the glomerulus and a cup-like container called Bowman's capsule, which surrounds the glomerulus. The renal tubule has three contiguous sections: the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule. Each renal tubule empties into a connecting tubule that leads to a collecting duct. Connecting tubules from many nephrons empty into each collecting duct. Blood reaches the glomerular capillaries through the afferent arteriole. Blood then leaves the glomerulus in the efferent arteriole, which supplies a network of peritubular capillaries. From the peritubular capillaries, capillary loops, the vasa recta, extend alongside the loop of Henle. If we think again of our recycling analogy, we can compare urine formation with throwing both garbage and unused needed materials into a bin, then taking back what we want to keep. Now, before taking the trash out, we add a final few waste items. Urine is formed in 3 steps: filtration, reabsorption, and secretion, which we will discuss in order.
Let's begin with filtration.
Blood pressure within the capillaries of the glomerulus is unusually high because the efferent arteriole is narrower than the afferent arteriole. This bottleneck effect helps to push water and solutes across the capillary walls and into Bowman's capsule. In doing so, water and solutes cross a filtration membrane consisting of the fenestrated endothelial cells, the lamina densa, and the slit pores created by the podocytes that cover the glomerulus. Blood cells and large proteins are too large to pass through the filtration membrane. As it travels along the nephron, the composition of the tubular fluid changes dramatically. Reabsorption is the second step in urine formation. Most reabsorption occurs along the proximal convoluted tubule. Reabsorbed material moves into the interstitial fluid and then diffuses into the peritubular capillaries. The last step in urine formation is secretion. Additional waste products are pumped into the filtrate. The DCT and collecting systems secrete acids, toxins, and drugs into the tubular fluid. Secretion occurs along the PCT in addition to reabsorption. By the time the tubular fluid reaches the collecting duct, at least 85% of the water and sodium ions have been removed for recycling. The tubular fluid arriving at the turn of the loop is highly concentrated after its journey along the descending limb. Unlike the descending limb, most of the ascending limb is impermeable to both water and solutes. Water is not reabsorbed here, nor can solutes diffuse into the tubular fluid. Sodium ions and chloride are the most abundant ions in the tubular fluid, and large amounts of sodium and chloride are pumped out of the tubular fluid as it travels along the ascending limb.
As these ions are pumped into the peritubular fluid, the solute concentration inside the tubule steadily decreases.
As the solute concentration decreases, fewer sodium and chloride ions are pumped out of the tubular fluid. Thus, the solute pumps along the ascending limb helps to create the concentration gradient responsible for concentrating the tubular fluid in the descending limb. This is a positive feedback loop. The pumping of solutes from the tubular fluid in the ascending limb adds to the concentration gradient within the medulla, which in turn draws additional water from the tubular fluid in the descending limb. The rise in the salt concentration of the tubular fluid reaching the ascending limb further stimulates sodium and chloride transport within the ascending limb. This phenomenon is called countercurrent multiplication. Countercurrent because the tubular fluid in the ascending and descending limbs travel in opposite directions, and multiplication because the positive feedback relationship multiplies the effect on water reabsorption in the descending limb and sodium and chloride transport in the ascending limb. The countercurrent mechanism performs two services for the kidneys. First, it is an efficient way to reabsorb solutes and water before the tubular fluid reaches the distal convoluted tubules and the collecting system. Second, it establishes a solute concentration gradient that will permit the passive reabsorption of water from the fluid in the collecting system as the collecting ducts pass through the medulla.
The urinary system is our friend. No matter how many times it wakes you up in the middle of the night, remember, the urinary system is working for you. Its main job is to constantly remove waste from our bodies by forming urine. It also maintains normal blood composition. So just like a water purification plant filters bad stuff out of water, the urinary system filters waste from the fluids in our bodies and returns good stuff to our blood. The whole urinary system is made up of a pair of kidneys, a pair of ureters, a single urinary bladder, and a single urethra. We'll tackle the kidneys first.
Section A, the kidneys and urine.
The kidneys are two bean-shaped organs. They're located in the superior lumbar region, an area discussed in the Anatomically Correct World of Anatomy, Part 1.
There are three regions in the kidney: the outer renal cortex, the middle renal medulla, and the inner renal pelvis. The kidneys are responsible for removing nitrogenous waste. That's waste that contains nitrogen. The kidneys remove these wastes by forming urine. This maintains a healthy acid-base fluid balance in the blood.
The main structures that make up the kidneys are tiny blood processing units called nephrons. They are the functional units of the kidneys, the workhorses, you might say. These little nephrons carry out the processes that form urine. And who could ask for a more fulfilling job?
There are over 1 million nephrons in each kidney. Each nephron is made up of a renal corpuscle and a renal tubule.
The renal corpuscle is responsible for glomerular filtration. Glomerular filtration is the first process in urine formation. The renal corpuscle is made up of two structures, the glomerulus and another structure called the glomerular, or Bowman's capsule.
Now, while the glomerulus may sound like a race of different-looking, and therefore evil, creatures from Star Trek, it's not. The glomerulus is actually a small tuft of capillaries. The glomerulus is surrounded by a capsule which is attached to the renal tubule, a structure that we'll give you the details on in just a moment.
The glomerular, or Bowman's capsule, is the other part of the renal corpuscle. Basically, it's a large cup-like structure that completely surrounds and engulfs the glomerulus, kind of like how a broken-in baseball glove engulfs a baseball. And don't forget, Bowman's capsule and the glomerulus also form the renal corpuscle, and it's in this section where the filtration of blood takes place. To sum it up, inside the renal corpuscle, bad stuff go bye-bye.
Just remember that the renal corpuscle is in charge of the glomerular filtration. You don't have to know that much detail, because hey, this is anatomy, not physiology. In any event, you do know about the glomerulus now. But still, that's only one of the structures that makes up a nephron. Another structure is the renal tubule.
The renal tubule's job is to selectively reabsorb water and substances like sodium, potassium, calcium, and other important stuff that's needed by the body. It also secretes waste no longer needed by the body.
The renal tubule is divided up into three regions.
These regions are the twisty-turny proximal convoluted tubule, the U-shaped loop of Henle, and the twisty-turny distal convoluted tubule.
The proximal convoluted tubule, or PCT, is the highly coiled region of the renal tubule that is continuous with the glomerular capsule.
Connected to the PCT is the loop of Henle. The loop of Henle is a hairpin loop that links both convoluted tubules, the PCT, and the distal convoluted tubule, or DCT for short. The portion extending from the PCT is called the descending limb of the loop of Henle. The portion connected to the distal convoluted tubule, or DCT, is the ascending limb of the loop of Henle. The distal convoluted tubule, or DCT, emerges from the loop of Henle and forms the final region of the renal tubule. In all of these tubules, water continues to be absorbed and waste continues to be deposited.
We're not going into detail on the formation of urine, so don't feel like you're missing anything. If you want to know more about urine, send a self-addressed stamped envelope to Fun with Urine, 2890 Emma Lee Street, Falls Church, Virginia, 22042. You'll be glad you did.
Well, that's the end of the renal tubule. Now, I know there's a lot of confusing loops, tubules, twists, and turns in the renal tubule, but that's because the extra length these curves create allows the renal tubule to process waste more effectively. More surface area means more filtration. So, do yourself and the renal tubule a favor and rewind the tape if you're confused or need a review.
When the urine formed in the renal tubules exits the DCT, it's delivered to a collecting duct. The collecting duct collects urine. Wow, what a great hobby.
The collecting duct collects urine from the DCTs of a whole lot of nephrons. You see, the millions of nephrons in your kidneys all have DCTs that empty out into collecting ducts. These collecting ducts deliver the urine to the renal pelvis. Then it flows into a ureter. Remember, each kidney has a ureter, so you have 2 ureters. But unfortunately, before we move on to the ureters, we have to talk about severe kidney disorders.
Sometimes, when a lot of nephrons are damaged or can't function right, a condition known as renal failure occurs. When this happens, people have to undergo dialysis, where they are placed on a machine called a dialysis machine.
Hemodialysis is the most common form of dialysis. In this process, blood is rerouted through a machine that contains a semi-permeable membrane suspended in a bathing solution. The membrane removes wastes from the blood and traps them in a bathing solution. Important substances the body needs can re-enter the blood from the bathing solution. Sometimes, in cases even more severe than this, a kidney transplant is required.
It's true. Renal failure is frightening. But never forget, all those other times when your kidneys are working, that's renal success. And now, on to the ureters.
There's not really much one can say about the ureters. They're really thin. They conduct urine from the kidneys to the urinary bladder. Pretty simple, huh? Now, the kidneys are an important part of the urinary system, but the precious urine they create would have no place to go were it not for the worm-like ureters, the cavernous urinary bladder, and the muscular urethra.
Section B, the urinary bladder and the urethra.
The urinary bladder and the urethra are the last few rest stops for urine on that highway of relief.
The bladder is a collapsible muscular sac that lies just behind and below the pubic symphysis. The pubic symphysis is the cartilage that connects the 2 sides of the pelvis. The bladder's prime job is to temporarily store the urine that's constantly being produced by the kidneys.
The next adventure on the urine itinerary is the urethra. The urethra is a muscular tube that transports urine from the bladder to the outside world so that everyone can enjoy it. All people.
The urethra contains 2 muscular structures called sphincters. It has an internal urethral sphincter made up of smooth muscle. The internal urethral sphincter is under involuntary control, meaning you can't control it consciously. The other sphincter in the urethra is the external urethral sphincter. It's made up of skeletal muscle and under voluntary control. We'll go into more details on the sphincters in a sec. Just let us elaborate on the urethra for a bit longer.
At 8 inches, the male urethra is a lot longer than the 1.5-inch female urethra. The male urethra also conducts urine and semen, while the female urethra conducts only urine. Well, that's the bladder and the urethra. You should be thankful for these organs. They make micturition, the act of emptying the bladder, possible.
You see, when the bladder fills up with urine, its smooth muscle contracts, causing the internal sphincter to open wide.
So if you're not ready to go because you're in church, running a road race, or dancing with your prom date, your body helps buy you some time.
We can use our external sphincter to temporarily delay the release of urine. You know, hold it in. This is because the external sphincter is under voluntary control.
Unfortunately, this little trick can only work for so long, because the external sphincter will eventually give way to building pressure, and then Niagara Falls. But hey, we're lucky we even have the ability to hold it in, and sometimes we take it for granted. Urinary incontinence is the inability to voluntarily control urination.
Urinary incontinence is normal in infants because babies haven't developed control over their voluntary external sphincter.
Unfortunately, incontinence in adults is usually caused by emotional trauma, pressure from the uterus during pregnancy, and nervous system disorders like multiple sclerosis. So if you're healthy, be thankful for your healthy urethra, as well as your bladder, kidneys, and ureters. By Job, be thankful for your entire urinary system, even on those cold winter nights when nature calls.